Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 468 of our pharmacotherapy series, which majors in adult hematologic malignancies. The next case reads, ENA is a 35-year-old female with a 2-week history of fevers, lymphadenopathy, malaise, and shortness of breath that was initially treated with antibiotics for suspected pneumonia. Progressive symptoms resulted in a hospital admission where radiologic evaluation revealed diffuse lymph node enlargement. So my first question to you reads, are ENA's symptoms consistent with aggressive or indolent lymphoma? ENA's presenting symptoms of fevers, lymphadenopathy, and malaise are all generalized signs of lymphoma, with the respiratory symptoms being consistent with pulmonary infiltration of malignant cells. The rapid onset and extensive disease involvement at presentation is suggestive of aggressive lymphoma. A biopsy of an involved node is essential to establish a definitive diagnosis and determine the subtype of lymphoma. My next question to you reads, what diagnostic evaluation is necessary to establish the diagnosis of lymphoma for ENA? Suspicion of lymphoma requires a confirmatory biopsy of the lymph node or involved tissues. Morphology, immunophenotyping, flow cytometry, and cytogenetic techniques are utilized to refine the diagnosis. Additional patient assessment should include a complete history and physical examination with a focus on lymph node-bearing areas, along with laboratory analysis, including CBC, comprehensive metabolic panel, and human immunodeficiency virus serology. Radiologic evaluation includes computerized tomography or PET to evaluate the extent of disease. Staging is based on the Ann Arbor system for Hodgkin lymphoma or the Lugano modifications for non-Hodgkin lymphoma. A bone marrow biopsy or lumbar puncture may be advisable under certain clinical circumstances. Assessment of baseline cardiac and pulmonary function is necessary for all patients expected to be treated with anthracyclines or bleomycin, respectively. We will now look at the treatment. Chemotherapy, immunotherapy, radiation, and bone marrow transplant are used in various combinations and sequences in lymphoma therapy. Selection of treatment is guided according to each specific classification of disease. Aggressive lymphomas, such as diffuse large B-cell lymphoma, abbreviated as DLBCL, and Hodgkin lymphoma, are treated with intensive combination chemotherapy regimens administered with a curative intent. In contrast, indolent lymphomas such as follicular lymphoma, abbreviated as FL, are essentially incurable and are regularly managed with an approach aimed at reducing disease burden and prolonging survival. Individual patient characteristics, including comorbid conditions and performance status, must be carefully considered in order to optimize outcomes. A biopsy of a supraclavicular lymph node confirms the diagnosis of aggressive non-Hodgkin lymphoma for ENA. My next question to you reads: what are some important supportive care considerations with lymphoma therapy? Beyond selecting the optimal chemotherapy regimen, care for ENA will require proper supportive care focused on addressing both treatment and disease-related complications. Prophylaxis and treatment of tumor lysis syndrome is vital upon therapy initiation, particularly for cases like this involving aggressive and bulky disease. Adequate antiemetics must accompany all chemotherapy. While common to virtually all lymphoma therapies, regimens designed for aggressive lymphoma are associated with significant hematologic toxicity and risk for infectious complications. As such, appropriate support with granulocyte colony stimulating factors, antibiotics, and blood product transfusions is imperative. Although the urgent need for treatment may preclude opportunities, fertility counseling for a patient of childbearing age like ENA should be offered. Delayed effects of both chemotherapy and radiation may develop more than a decade after conclusion of therapy and include secondary malignancy, cardiovascular disease, and pulmonary dysfunction. Subsequently, survivorship programs designed to monitor for delayed complications of treatment are increasingly valuable when treating theoretically curative diseases. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 469.